how to approach fever and a patient in a hospital. So far, you deal how the approach to fever in the community as well as fever in the OPD settings. Now we are moving to the hospitalized patients. This 4-5 weeks, we are focusing more on hospitalized patient settings. And today is the first session of the nosocomial event. So fever in the hospitalized patients with more focus on ICU also, she's going to touch upon it. And please don't put your name as a attendance sheet. As a rule in infectious disease short certificate program, you need to actively participate with the faculty, putting your questions as answering the poll questions, then only get the attendance. This is a clear rule. Typing the name, you don't get the attendance. You need to participate actively. How many participations happening in a chat bot, then only we give the attendance to you there. So don't just type the name in chat bot and get the attendance. Don't expect the thing. Keep the video as much as possible open and try to interact with the faculty. Whenever the polling questions or whenever the discussion point initiated by the speaker or the moderator, you just start answering in the chat so that we can have your attendance whether you're involved or not. That's more important. Without further ado, I asked Dr. Vidya Lakshmi to take over the sessions. Vidya, thanks for accepting one more time. Please start your session.
Thanks a lot, sir. It's always a pleasure to be a part of the meetings that you organize. You're very informative. Hopefully, I should be able to convey whatever possible. Very nice to see such a good participation, especially on a weekend. Okay, so this is like the fag end of the day. I'm sure all of you are extremely tired, but definitely I'll try my best not to keep this as my objective. So basically, I will put forth a lot of case scenarios. And in infectious diseases, it's always making a syndromic approach. Then you choose your antibiotic therapy based on that. So if you look at humanity, it has three great enemies. This was said by Sir William Osler. And if you look at other than famine and wars, it is fever, which I'm sure all of you will agree completely, because fever is definitely one of our enemies, one of the enemies of a practicing physician. So I will again retaliate of this. By far the greatest, by far the most terrible is fever. So how do we approach a patient with fever? So patient comes in with a febrile illness. That is when you will have to ascertain the cause of fever. Next is patient in the ICU develops fever. You'll have to know what is causing the fever, because not every fever is deficiency of antibiotics, or not every fever is an infection. So patients presenting with a febrile illness make a syndromic approach. Is there a focus of infection, or is it acute undifferentiated fever? So this is somebody who comes to you with a febrile illness. I'm sure a lot of it would have already got dealt with in your previous sessions. And the other part that we're going to look at is also patient developing fever in the ICU. So patient developing fever in the ICU, you could have an infectious cause. If it's an infectious cause, it is important to make a syndromic diagnosis or to find out where is the focus. If it's a non-infectious cause, there are a number of them. You need to know what is causing the fever. Otherwise, this is going to result in irrational, prolonged use of antibiotics, which is really, which definitely needs to be looked into, which is the need of the hour. So when you look at patient developing fever in the ICU, it could be an infectious cause or it could be a non-infectious cause. If it's an infectious cause, look at where the focus is. So first of all, when do we say patient has fever in the ICU? This is the Society of Critical Care Medicine and Infectious Diseases Society of America. They recommend investigations in the ICU if the temperature is about 38.3 degrees centigrade, which is 101 Fahrenheit. At the same time, one important thing that you have to know is patients who are immunosuppressed, elderly, patients with end organ damage may not just present with fever. So they can just have encephalopathy, they can have hemodynamic instability or derangement in organ functions, which could also mean sepsis. So you have both ends. You have somebody who can present to you, they can have encephalopathy or all these symptoms, signs that I told you, but then the Society of Critical Care Medicine says that you'll have to investigate ICU fever if it's more than 101 degrees Fahrenheit. So what are the infectious causes of fever while the ICU? First of all, you just have to think of all the tubes that the patient is on, or all the plastics that is in. So ventilator-associated pneumonias, then you can have lines. So it could be catheter-related bloodstream infections. When you have Foley's, you'll have to also look at UTIs, intra-abdominal infections, sometimes prolonged hospitalized patients. Acalculous cholecystitis could be one important cause of fever. Diarrheas, which could be antibiotic-related. Sinus infections in patients with prolonged Rayleigh tube. So if you look at the distribution of fever in the ward and the ICU, in the ICU, obviously, you will look for bacteremias, ventilator-associated events, most so in the ward because patient may be on Foley's, you have to look for urosepsis. Like I mentioned, candidemia is one important fungal infection, which is the cause of fever in the ICU or sepsis in the ICU, particularly when you see patients with specific risk factors who have negative cultures, then you'll have to look at candida as one of the cause. Risk factors like lines, TPN, broad spectrum antibiotic, immune suppression, intra-abdominal surgeries, candida colonization, repeated culture negative sepsis. With any of these risk factors, what we call as a candida score is one of the causes could be sepsis. Cause for sepsis could be candidemia. So look for surgical site infections. They may also denote some deep organ infections, like I mentioned, acalculous cholecystitis, endocarditis, meningitis, etc. So I will go to a few cases now. You have a 65-year-old male based in Chennai, comes to your ICU with fever of 6 days duration, altered mental status and dyspnea of 2 days. Fever is high grade, continuous, Tmax of 103, altered sensorium since a day, cough of 4 days, no sputum, no comorbid illnesses. So not on any specific regular medications, no history of alcohol abuse or drug abuse. Important clue in this history is he has been on a beta-lactam for 3 days, not shown a major improvement. That is a Moxclav for the last 3 days and not really improved. Yes, travel history is very important. Infectious diseases, travel history, what antibiotic exposure that the patient has had prior, because if they've not improved on something specific, you'll have to look for loopholes in the spectrum. So this patient had some history of travel to Nellore on examination, no skin rash, oral cavity is normal, GCS was 11/15, had mild splenomegaly, crackles on examination, very high fever, but WBCs were normal, platelets were borderline. He had a cholestatic or probably a mixed pattern liver picture. So if you look at every organ system is by and large CNS, you have respiratory symptoms, you have thrombocytopenia, you have a cholestatic liver picture, typical patient presenting to your ICU. So this is what the chest X-ray showed, extensive bilateral infiltrates. So, but then how you have to approach this is fever, normal counts, and multi-organ involvement. Could be malaria, yes. Could be scrub. It could be systemic sepsis with ARDS. If so, you'll have to find the focus. Can it be lepto or leptomemory syndromes, malaria, scrub, or systemic sepsis, ARDS? The syndrome here, predominantly altered mental status. It could be encephalopathy or it could be meningoencephalitis. CSF was done in this patient. Lymphocytic, proteins raised, gram stain negative, culture negative, fungal stains negative. Basic tropical workup, dengue, IgG positive, malarial smear negative, leptoserology negative, MRI brain normal. So ensure you completely, thoroughly examine the patient. This was the eschar of scrub typhus. So ensure scrub typhus definitely can present to your ICU like a sepsis syndrome. Okay, so scrub typhus with the ARDS, what is scrub? Rickettsiosis are zoonotic bacterial infections transmitted to humans by arthropods. Orientia sisugamushi, That's caused by a sugar bite. That's a rickettsia. So if you look at this study, which is from CMC of acute febrile illnesses, scrub typhus was one of the important causes. About 48% of scrub, 189 cases were that of scrub. Typically have a multi-system involvement. Confirmation is by of rickettsial infections require clinical, epidemiological, and lab data. What about eschar? It can be seen only in 50%. So remember, you could have a lot of patients without an eschar. So does not mean absence of an eschar is scrub ruled out. So you have to look for an eschar. Though, look for specific locations of the eschar. Appearance is usually like a cigarette burn. So that's the eschar parade that we have, distribution of the eschar like I've shown you in pictures. It can cause severe manifestations which can present your ICU with ARDS, meningitis, jaundice, renal failure, multi-organ failure, etc. Serology will help in diagnosis, immunofluorescence or immunoperoxidase, PCR, yes, from the skin biopsy or lymph node, but not, you can't get this in a lot of places. IgM ELISA does have a good sensitivity and specificity. So treatment is using doxycycline. In severe cases, you have a recent NEJM which says you have to use doxycycline with azithromycin, and the dose there is for the usual scrub, mild or moderate, whereas in severe scrub, you use a higher dose of doxy. In CNS involvement, yes, we have used chloramphenicol. Rifampicin is another drug which does have action on scrub, but I mean, please keep it for your tuberculosis. Azithromycin, doxycycline, no response to beta-lactam. So this is a patient who presented fever with normal counts to your ICU with multi-system involvement and no clear response to beta-lactam. Plus or minus the eschar, this tropical infections to your ICU is an important cause of sepsis in ICU. So this is a publication from, I think, Suresh sir and me, Dr. Nambi and all were there during this time, where we had about 5% who died of MODS. So they can present to you with ICU infection. This is a paper which is a pediatric scrub. You definitely have to look for this entity in children as well. So take home message from this case: sepsis does not require high-end antibiotic always. Search and you shall find. Definitely look for cutaneous manifestations. One of that is an eschar in this patient. So I have another patient, which is a 47-year-old, presents with upper abdominal pain with high-grade fever of 6 weeks duration. Review of other systems, non-contributory. Important to look at your occupational history. He was an agriculturist. Comorbids, again, he's a diabetic. He has his own farm. Diagnosis of liver abscess was made outside and he got started on antibiotic. Fever persists, presents to us. So in such cases, it's not enough if you just pick up the syndrome. Look if you have to source reduce. So aspiration of this liver abscesses, getting the bug right, etc. will definitely be of help. So at admission, he was toxic with high-grade fever. Spleen tip was palpable, had a tender hepatomegaly. Leukocytosis with polymorphonuclear nuclear cells. Bilirubin was elevated, alkaline phosphatase was elevated, ultrasound showed 2 hypoechoic lesions. 20 ml of pus was drained from the abscess. So any guesses for diabetic, liver abscess, agriculture? This should definitely give you a clue. So this was what was seen on the pus, which is gram-negative bacilli showing bipolar staining, which is closed safety pin appearance. So what was grown was a non-fermentar. Yes, in many places, non-fermentars are not identified and are discarded. What you must know is liaising with your lab. MALD will not pick up the identification, especially of this organism. You will have to talk to your microbiologist to specifically look for or discuss with them that you're looking for this entity called Burkholderia pseudomallei or melioidosis. So this patient had melioidosis. So melioidosis was the Vietnamese time bomb, long latency. It can present with acute sepsis syndromes. It can mimic TB as well. So increasingly being reported in India, it can present with sepsis, abscesses, chronic pneumonias, easily treatable, and you need to liaise with the lab. Caused by Burkholderia pseudomyeli, non-fermenter. Ensure when non-fermenters are reported in your lab, they should not be disregarded as contaminants. It could very well be melioid, may get missed on MALDI. So ensure that you discuss with them. So if you look at melioidosis epidemiology, it is one of the commonest causes of community-acquired sepsis and fatal pneumonias in Thailand. You have like Vietnam, Cambodia, Andaman, Nicobar, etc. Your Thailand literally reports 3,000 cases yearly. It is definitely there in India. So if you look at this map, high endemic area is India as well for melioid. Risk factors: ethanol, diabetes mellitus, renal disease, chronic lung disease, steroids. It's an intracellular pathogen. That is why they have latency. They can present with pneumonia, sepsis with or without multifocal abscesses in about 10%. You may have cutaneous infections, bone and joint infections, chronic pneumonias, acute pneumonia with sepsis. This is a CT showing a large pulmonary abscess with cavitation. It could mimic TB, like I said, and multiple visceral abscesses. So when you have splenic abscess, not just Staph aureus, you'll have to think of Klebsiella. You'll have to definitely keep melioid in mind. Prostatic abscess, one of the organism for predilection for prostate apart from crypto is also Burkholderia pseudomyeli. So this is, 21%, this paper actually said that's a urology journal, 21% of all melioid patients in North Australia had prostatic abscess. So it's not really uncommon. Look for it. Septic arthritis, vertebral osteomyelitis, cerebral abscesses, neuromelioid cerebral abscesses is one important. We did see actually in, I think, 2015, post floods in Chennai, we had like a bunch of them coming to us with melioid with various presentations, including parotitis. So diagnosis, it grows readily in your blood culture medium. All that you need is to talk to the lab. Ashdown medium is used for transport. In endemic areas, serology may not be helpful. PCR is useful for specimens other than blood. So that's how your Burkholderia pseudomyeli looks. So I'm not going to go in detail into treatment, but you could use drugs like meropenem, ceftazidime. You could use doxycycline, amoxiclav. So these are some of the drugs which cotrimoxazole. Important. So these are some drugs which work against Burkholderia pseudomyeli. Now I have the third patient, 60-year-old gentleman, diagnosed to have CA rectum. He's had APR. He's on TPN, 10 days into ICU stay. So someone with a GI surgery, he's on TPN, 10 days into ICU stay. He had a surgical site infection with E. coli, so he was treated with cefoperazone sulbactam. He's off antibiotics 2 days. Peripheral IV access is difficult, so he has a right jugular line in for some time now. He has a Foley's in. He has high fever and you get called for. His blood pressure is borderline. So now what do you think is the differential? So somebody who's been on prolonged antibiotic, he has a central line in, he's had an abdominal surgery. So if you've listened carefully to the initial part of my talk, I'm sure you would pick up the diagnosis. So I'm again showing you the salient points before you make a diagnosis here. So what are your differentials? So in ID, like I said, make a syndromic diagnosis. Can it be intra-abdominal infections? Yes. Somebody with a superficial surgical site infection can very well have an organ space infection. Can it be CRBSI? It can be line related. He has a prolonged line in. Can it be CAUTI? Can it be non-infectious causes? Okay, yes, it can be DVT. So this patient had a CRBSI. That is clinical catheter site infection or systemic signs of sepsis with a positive catheter culture, which could be quantitative, semi-quantitative, same organism growing in peripheral blood. So pathogenesis in this, CRBSI can either come from the surface, from the distant site, or it could be from the hub. That is why it's important to scrub the hub. So the cause of CRBSI can be many. One such cause definitely is Candida in this patient, but you will definitely see what grew because you will have to look for loopholes in the spectrum. So what are the risk factors for CRBSI? Remember, compared to subclavian, femoral site is more thrombogenic and it is more infection prone. It is also duration of catheter use. The patient state is like critical illness, immunosuppression, TPN, burns are all risk factors. So earlier the better, get the catheter out. On your daily rounds, make sure you review the need for every plastic that's in the patient to ensure that you are on track. Like review the need, whether you can extubate, whether you can remove Foley's, do you really need Foley's? Can you remove line? Make sure you look at peripheral venous sites for phlebitis or phlebitis scoring. So what are the common organisms causing CRBSI? Okay, if you look at the Western data, it could be Staph aureus, but when you look at Indian data, you definitely have a lot of gram-negatives. It can be Acinetobacter, it can be Burkholderia cepacia or Elizabeth, Pseudomonas, Enterobacteriaceae, etc. can be the causes. Cons, which is a contaminant generally, do not disregard it, especially if you have a line in and multiple bottles are growing the same organism in the presence of prosthesis. So if you have a line in coagulase negative staph in multiple bottles, it is important to rule out cons causing the central line associated bacteremia. All that it requires is removing the line and treating for a shorter duration. So this patient received cephalosporin sulbactam. So this patient, Enterococcus selected out. So like I said, please look for loopholes in the spectrum. He actually had E. coli bacteremia. He was on cephalosporin sulbactam. So what can select out is Enterococci, resistant gram-negatives, Candida can select out. So your antibiotic choice will be based on your syndromic diagnosis and what are the usual pathogens that cause that particular syndrome. So this patient had enterococcal bacteremia. So evidence-based approach to prevention of CLABSI, Pario method while placement. Chlorhexidine is better than povidone iodine for skin prep. Prefer the subclavian site. Remove the catheter when it is not needed, and then antibiotic impregnated catheters. Preventing ventilator-associated pneumonia is important thing to get the ventilator off. Keep them in a semi-recumbent position. Avoid routine stress ulcer prophylaxis. Sucralfate is better. Subglottic suctioning. Avoid tubing change every 24 hours. Avoid nasal intubation. So intubation for mechanical ventilation increases the risk of pneumonia from 3 to 21 times. I have my next case. That's the fourth one. 72-year-old, day 15. Dynamic hip screw for right hip. Sorry, I'm using some short forms there, but it's a dynamic hip screw. Post-op, he had a UTI that is treated. He develops new fever spikes. So he's febrile. He has tachycardia. He has scattered V's. Extremities are edematous. So can this be pneumonia? It can. Atelectasis. Yes. Implant infection. It could be. Can it be UTI relapse? It could be. Can it be cellulitis? Little less likely because edematous limbs. Important to think about both infectious, non-infectious etiologies. Not every fever means infection. So his echo showed an RV dysfunction. Doppler lower limb showed DVT. So please look out for non-infectious causes of fever in the ICU. So what are the non-infectious causes for fever in the ICU? It could be subarachnoid hemorrhage, pontine hemorrhage. So any of your bleeds can cause, especially when it comes to neuro ICU. Not every fever is going to be an infection. Similarly, you have MI, pericarditis. You could have pulmonary embolism, atelectasis, which is very common, and you could have fever due to the same. Ischemic bowel, a GI bleed can cause a high white count as well as a fever in the ICU. Adrenal insufficiency is again a cause for fever in the ICU. DVT, thrombophlebitis, something that's very common, which you have to really look at during your ward rounds. You'll have somebody settling down on a specific syndrome or infection that you're treating. Everything gets better. Suddenly you have a new fever. You have to really look for his line sight. Very common cause of fever, thrombophlebitis. Remember, prolonged beta-lactams, blood transfusion, etc. can also cause fever in your ICU. So we have our next case. So that case gives you a very clear message that not every fever is infection, and what are the causes for non-infectious, or what are the non-infectious causes for fever in a patient who's hospitalized or is in the ICU. I have a next patient admitted post RTA, has a CSF leak. Get started on ceftriaxone. Ideally, no role for prophylactic ceftriaxone. However, he gets started on it. Stable, afebrile for 8 days. Everybody forgets to look at the drug chart. So, ceftriaxone is on for a while. He starts to get high-grade fever. Nothing to localize clinically. Elevated WBCs, eosinophils, elevated ESR. His LFT, there is some marginal transaminitis. He has a faint rash. So again, look for non-infectious causes. Drug fever. Many a times, I'm sure you would pick up beta-lactam fever in your patients. So drug chart was reviewed, especially your neuro patients. I know phenytoin is not used as much, but phenytoin, ceftriaxone, beta-lactam for a long time in this patient could be a cause for fever. So in drug fever, pattern of fever is variable. They could have rigors, myalgias, rashes, unexplained high spiking. Usually, remember, the rash in this fever usually comes on day 6, day 7, and your fever starts in the second week of drug administration. Just because it's a drug fever, no ma'am, we've started this drug 10 days ago. It may not be due to the drug. The rash may not be due to the drug. No, that's not what it is. Median time to onset of the rash is later, not immediately. I'm talking about a drug rash. It is much later. So this could definitely be a cause for fever in your ICU. Can be associated with leukocytosis and eosinophilia. They could have, though they report relative bradycardia, it's not so commonly seen. Look for associated skin rash. May take up to 72 hours for the fever to resolve. Basically, they look unusually well for the degree of fever that they have. So inappropriately well for the degree of fever. So any kind of drug can cause, specifically, what we see, if you look at oncology patients, cytarabine, you look at patients who are getting prophylaxis with liposomal amphotericin B can be the cause of drug fever, cephalosporins, penicillins, etc., atropine can cause drug fever. And the cause for in-hospital fever, if you look from this study, was infectious in 37 to 74%. Look at the chunk, 3 to 50% can be non-infectious. You may not be able to make a diagnosis in every case with fever. In this study, 87% they had a definitive diagnosis. Common cause in this for hospital acquired or nosocomial infection related fever could be pneumonias, UTI, bloodstream infections. Whereas when you look at non-infectious fevers, it could be blood transfusion, ischemic conditions, infarctions, DVT, and malignancy. Then I have probably a couple of cases more, and then I will leave it for discussion. This is a patient with post-CABG. You're seeing him. So one of them was in the neuro ICU. One was in the surgical ICU. Couple of them in the medical ICU that you saw. Now this patient is in a cardiothoracic ICU. So post-CABG, day 1, high-grade fever, leukocytosis, All of us have tachycardia. You have the treating, the surgeon has, all of you have tachycardia, leukocytosis is seen in this patient. And so what do you think? So this very well can just be post-operative fever. So post-op SIRS can occur due to tissue trauma, and it is one of the important causes for post-op fever. Just give me a minute. Empiric antibiotics should be withheld in patients with fever within 48 hours of surgery if they lack a specific diagnosis for after thorough evaluation. Continuing perioperative prophylactic antibiotic. Again, this is an important take home. Continuing perioperative prophylaxis or prophylactic antibiotics will not prevent infection. What it will do, it will only select out for resistant organism. So this is one study which actually looked at post-op fever. 72% of the fevers within 48 hours of surgery was actually non-infectious. But whatever occurred, like say your respiratory infections, wound infections, everything was post 48 hours. Watch out for thyrotoxicosis, like I said, adrenal insufficiencies, especially adrenal in your ICU, which can present with fever. Now, coming to antibiotic prescription in your ICU, I would say, or in general, is definitely an art. So you have a 45-year-old patient with analgesic abuse. He comes in with abdominal pain, undergoes emergency laparotomy, omental patch, gets started on meropenem, gentamicin, metrogyl. So what is right or what is wrong in this prescription? Patient was shifted to SICU, surgical ICU, afebrile on ventilator, not on inotropes, white count is normal, platelet is slightly low, pus culture is ESBL E. coli, sensitive to piperacin, tazobactam. So what was wrong in that patient? You definitely do not require redundant anaerobic coverage. So this patient does not require meropenem plus metrogyl. Meropenem will cover more than 95% of anaerobes, and please keep the metrogyl gentamicin off. So if you look at the anaerobic activity of a lot of drugs, meropenem, imipenem, BLBLIs definitely do have good anaerobic activity. So avoid redundant double anaerobic gram-negative coverage or anaerobes in your ICU. So this is how we are abusing antibiotics. Duration of therapy longer than needed in 33%, 32% non-infectious, non-bacterial syndromes, treatment of colonization and contamination in 16%, redundant anaerobic cover or therapy or dual therapy in 10%. So this is another patient. The same patient, say he gets discharged, comes back for suture removal, short-term Foley's, well, otherwise examination is good. Somebody does a urine routine on him and finds 14 pus cells and then does a urine culture. Do you have this organism growing? What do? Do you treat? Ignore. So remember, this is asymptomatic bacteriuria. This patient unnecessarily received meropenem. So ultimately, this will result in C. diff. It will result in selecting out more resistant organisms and the meropenem failing on the next time when it gets treated. So always treat infection and not colonization in your ICU. treat pneumonia, not the tracheal aspirate or the endotracheal tube tip. Treat urinary tract infection and not just the indwelling catheter or an asymptomatic bacteriuria. Treat the bacteremia and not the catheter tip alone. Again, when it comes to bone infections, pressure sore, it's not, or SSI, it's not the swab. You have to get an appropriate sample. You have to understand what is music, what is noise, what are colonizers, and do not treat colonizers or contaminant. So another very similar case that you will actually see somebody presents with fever and cough and otherwise stable except for some tachycardia and X-ray. This is what the sputum culture shows. Sputum culture showing MRSA. Patient gets started on daptomycin. Traditional misconception, taking like Petri dish matching drug to the bug. One size will not fit all when it comes to dose duration. Okay, so what you have to know is this daptomycin was used in this patient. Daptomycin will get denatured by the pulmonary surfactant. So you have to make your syndromic diagnosis, choose an appropriate antibiotic. So do not use antibiotics which are not efficacious at the site of infection. For example, poly B in urosepsis or BLBLIs when you're looking at meningitis may not really penetrate well. Daptomycin in lung infections. These are all quick cases that you will come across. Multiple myeloma, fever cough for 3 days, X-ray showing consolidation. Sputum now is showing Candida glabrata. I've told you so much about Candida. What should you do to this? This is a patient whose X-ray showing a consolidation. Sputum is growing yeast. And it is Candida glabrata. What do? Would you treat? Not treat. What next? How are we supposed to react to this sputum result? So remember, Candida is most likely a colonizer. So all fungi recovered from sterile site should be identified down to the species level. Yeast, if found in sputum or bowel fluid, should be regarded as contamination or colonization until you prove that it is an invasive disease. So growth of Candida from respiratory samples rarely require treatment with antifungal therapy. I'm sure you'll find that in your ICU as well. You do a BAL, you'll get, or you do a ET culture, you get yeast, and then you say this is Candida pneumonia. No, it does not work that way. This is another patient with oral CA, comes with fever, high grade, no other clinical localization, surgical. He's had recent surgery for the oral CA. He has leukocytosis, urine and blood culture is already sent. Urine culture grows gram-negative. Urine culture grows carbapenem-resistant Klebsiella. Blood culture sterile, assumed to be CORT. Foley is removed, gets started on colistin, and that gets treated. He settles down. Fever starts again. Surgical site is clean. Now WBC is increased to 19,000. Other causes are ruled out. Central line is still in. So this patient asks always for a paired blood culture. So this paired blood culture actually grew Candida. So you should know when to ignore it, when to actually treat. But if you think of Candida sepsis in a patient, you definitely have to treat it before you miss the bus. So like I said, this is the patient who carry risk for candidemia, exposure to broad spectrum antibiotic, GI surgeries, neutropenics, high colonization index, septic shock with risk factors, negative procal, negative cultures, not improving on antibacterial cover. Think of Candida. Remember to watch out for this entity called Candida auris in the ICU. Not many misidentifications can take place with this Candida. You have a lot of risk factors, including admission to ICU itself, which was a risk factor for Candida auris. This is an Indian study. They are MDRs. They are just like your multi-drug resistance. Bugs require appropriate infection control. They've caused a lot of outbreaks. First one was, in fact, in a cardiothoracic unit. So usually we look at echinocandins, and 5.2% of candidemia patients in ICUs in India do have oris. So initial therapy is with an echinocandin. Then get your susceptibilities and rationalize. When you look at Candida, it kills, hit hard, hit early, hit wisely. Know whether it's albicans, non-albicans. Echinocandin is definitely the initial drug of choice. Treat candidemia for 2 weeks after the last negative culture. Step down treatment to azole if it's acceptable after 5 days, provided there are factors like the patient has gotten better, patient's culture has cleared, and if it's a non-neutropenic, please get the line out. A strong intuition is much more powerful than a weak test. So when you look at opportunistic yeast, fungi, they won't wait. Dear optimist, pessimist, and realist, while you guys are arguing about the glass of water being half full, half empty, I drank it. This is what they actually do. So if you have a suspicion, please start therapy. Otherwise, Candida will kill. So common things are always common. All yeasts, again, are not Candida in your ICU. If you're looking at transplant ICUs, neutropenic patients, you have to look at other yeasts like Trichosporon, Geotrichum, Saprochaete, etc. in mind. Always interpret fungal markers with caution. So when it comes to all your ICU patients, not all fevers are infection. Every ID problem has two components: syndrome, microbiological etiology. Response to fever is an evaluation and not initiation of antibiotics. Look for non-infectious causes for fever. Patient with severe sepsis at the same time, remember, can be afebrile, they can be hypothermic. Get your cultures, not just the cultures. Get adequate amount of cultures. There is no concept of pan cultures in your ICU. You have to ensure that you make a syndromic diagnosis and get the appropriate cultures, good volume of blood cultures before you start your antibiotics. You have to know your enemy if you have to hit hard. So know your local organisms, what causes VAP, what causes BSI in your unit. And then you start the patient on your antibiotic. More important to know what sort of a person this disease has than what sort of disease this person has. We are running out of antibiotics. We're going into an antibiotic-free era. Yes, in a fight, you have to hit hard, hit first, hit hard, but please hit wisely. Preserve antibiotics. Remember, everything that glitters is not gold. Not all fevers are infections. You hold the solution. So don't just look at culture and know what to treat, what not to treat. So, I usually end my talk with this saying, happy birthday penicillin, may your tribe increase, because at some point we will run out of antibiotics and it's very important to preserve them, especially when you're dealing with immunosuppressors, patients that you're dealing with in the ICU. Thank you.
Thank you, Vijay. Thanks for your wonderful presentations and sticking to the time also. And more importantly, you discussed case-based approach. Most of the faculties, they discuss theory, but you did their case-based approach. And examination, you showed a couple of important things. Examination is very important. Think about non-infectious causes. Don't do pan cultures. Do your focused examinations and get the answers. And you attach a lot of cases to the participants there, and a lot of discussions also happening in the participants. This is one of the presentations we saw a lot of interactions with the participants during your presentations. And a couple more questions also they posted here. So I'll start with the questions. One of the interesting questions they posted. Bactericidal and bacteriostatic agents for a bacteremia. What is your comments? Bactericidal agents or
first of all, we're
bacteriostatic?
not looking at anything called bactericidal and bacteriostatic. But yes, when it comes to treatment of bacteremias, we do look at bactericidal agents. So, for example, if you take linezolid, we don't really prefer to start that in bacteremias, but many times you may not have a choice. So,
and second question is in aspergillus in bowel galactoma. Aspergillus is positive in bowel cistern, whether you treat or not.
Again, you have this criteria called URCTC MSG criteria, where you have to know what is your host, what is the radiological finding, what is your mycological, what are the mycological factors. Okay, so in that, if you look at, so who are the hosts who are at risk for aspergillus? It's not that, you have a community-acquired pneumonia and then you just get a BAL and galactomannan is positive, start on aspergillus therapy. It is somebody not responding to your routine antibacterials, neutropenics or immunosuppressed. Yes, emerging risk factors like chronic liver diseases, organ transplant patients. So these are some of the risk factors. So you have to take your host, your radiology into consideration before just looking at, like I said, interpret biomarkers with caution.
So ideally, we need to take the host into considerations rather than culture report alone. Always don't read the paper, read the patient's input. That's what he's telling it there. Couple of comments about the levonorephoxacin and cefepime N-metatrexobactam. People are promoting like anything and they are using also. What is your comments? Where to fit these two antibiotics in your practice?
Okay, again, coming to levonorephoxacin, I think we will look at, if at all, we are going to look at it. I've not, to be very frank, I've not used it much. If at all there is anything, it may have some role in joint infections or prosthetic joints where you don't have enough of gram-positive agents. That's the only place as of now that I would look at this molecule. I have not used it, and I've not used it as much, and that's the truth.
It has got a good MRSA cover, but we as a ID doctors, we usually won't prefer it because we got other good MRSA agents and it's very costly also. Compared to comparative agents, it's very costly, so we don't try it. And the other options is that cefepime N-metatrexobactam is for ESBL producing organisms and AMC producing organisms. It is a better choice, but again, as you said, it's got very limited role. Not every sepsis is taken care of with cefepime N-metatrexobactam. In similar note, people are asking about ferropinum also. That is
Again, ferropinum is not a carbapenem. So do not put a patient with sepsis on meropenem and send him home on ferropinum. Ferropinum is a pinam. You don't have really, susceptibility breakpoints, etc. that have been described. In fact, using these may predispose them to get carbapenem resistance. That's what literature actually says. So it is a pinam, it's just got a fancy name. So please be very careful when you use it.
And one more case scenario they provided. They got a parotid abscess, recurrent parotid abscess, despite good number of antibiotics, and they drained surgically also. There is no local oral issues, but still the parotid abscess is persisting. What to do?
Okay, first of all, we'll have to look at, if you have a negative culture, you could definitely use some PCR based or NGS techniques, because you'll have to know what the cause of the parotid abscess is. Look for any abnormalities in the ductal tract. If you have had a good xylogram, etc., which is you have some obstruction. Sometimes if it is sterile and it's just recurrent parotitis, then you'll have to work up for autoimmune causes, because there are causes like sarcoid and other autoimmune which can present with parotid enlargement.
I agree with you, because once the patient is not improving, we need to go back and relook our diagnosis is correct or not. Because you are using appropriate antibiotic, doing a surgical drainage, still the patient is not responding, means think your diagnosis is correct or not. Think non-infectious etiology, mimicking infectious etiology. That's what she told. Autoimmune diseases should be thought of here in this case. One more case, my microbiologist is giving for MDR E. coli, polymyxin is sensitive. What to do?
Okay, so if it is an E. coli, please see if what syndrome you're looking at again. I would want to request the microbiologist for ceftazidime, avibactam, astronam synergy testing, because a lot of our E. colis are NDM producers. I would definitely ask for some synergy testing and use ceftazidime, avibactam plus astronam after synergy testing if there is synergy. There is no synergy, then we cannot be choosers. If it's not a urosepsis syndrome, many of us still rely on polymyxin B.
Regarding meropenem dosage, is there any differences according to the MIC differences? According to MIC, I can adjust the dosage of meropenem. That's the question he's asking.
Okay, so we generally, especially in the first few hours of sepsis, irrespective of what the clearance is and anything, you have to go on high dose of antibiotics, which could even go up to 2 grams. And if at all you have organisms which are more than 8, MIC of carbapenem, which is more than 8, that is mero and IMI, we do not really use it even for combination.
Then one more interesting question. Acute pyelonephritis, many of the urologists favor DJ stents if fever doesn't settle by 48 to 72 hours. Is this informed by evidence? What is the really indicated? When to stent?
I think, disclosure, I'm not a urologist, but if there is no papillary necrosis, obstructive uropathy, putting in another plastic may predispose him to have a stent infection as well. So you'll have to really review the need for such an intervention prior to blindly putting stent in, irrespective of, of an obstructive uropathy or a papillary necrosis being there.
Yes, I agree with you. Most of the urologists now preferring stenting for each and everything. But usually when the system is dilated or when you think about emphysematous pyelonephritis or papillary necrosis, we need to go for source control. Yes, it might help out. Or dilated system, still the patient is not responding. Yes. Otherwise, very limited role, but urologists are pushing for most of the things there. And couple of prevention questions they are asking. Is there any role for betadine wash for bladder wash for cystitis?
I'm not aware of such a recommendation. If it's cystitis, I'm not aware of a recommendation using betadine washes. So I think if it's not on the guideline recommendation, we should not be using it.
I agree with you. There is no evidence to show betadine wash to prevent the cystitis or treatment for cystitis is also not recommended. One more thing, prophylactic antibiotics to prevent cellulitis in peripheral catheters, peripheral intravenous catheters. Prophylactic antibiotics to prevent.
Prophylactic antibiotics these days are in very few conditions, including in neutropenia. We have enough evidence that we are not using prophylactic antibiotics because you do not have antibiotics to use. So prophylactic antibiotics for peripheral line to prevent cellulitis, at least from my end as an ID physician, is a no-no. If you say cellulitis as such, syndromes which can be caused because of strep, staph, etc., there may be roles for penicillins, but for a peripheral line, I don't think there is a role.
In vitro sensitive ertapenem enterobacter UTI infections, but failed to respond to good doses. What should be done?
Okay, first thing. Okay, so it is in vitro sensitive. Look for source reduction. In such a patient is when you actually have to look for source reduction, whether it's done. If it's not, the next thing is to look at appropriate dosing of the drug, adjusting it to the host risk factors, including clearance, etc. Many a times in sepsis syndromes, beta-lactams are underdosed.
Your take on polymyxin and fosfomycin monotherapy?
Okay, so again, it depends on what I'm treating. If I'm looking at polymyxins for Acinetobacter, serious infections due to Acinetobacter, like in an ICU patient, ventilator-associated pneumonias, bacteremias, I would not generally use polymyxin as a single agent. I would try to combine it with minocycline, etc. For certain group of patients, yes, poly and phospho, when I don't have many other antibiotics, we do use. Fosfomycin, we do not use it as monotherapy. Again, fosfomycin oral is used only for uncomplicated cystitis. IV fosfomycin is not used alone. Tendency to develop resistance when you use it alone is very much documented. So generally used for Enterobacteriaceae therapy in combination with other drugs. Fosfomycin IV is not a good drug for Pseudomonas or Acinetobacter again.
Treatment of a drug fever when you are treating with an antibiotic for a susceptible bug. We are using a drug that is causing a fever, but is susceptible to the drug. What will you do?
See, again, shorter the better is the mantra now. Okay. So if you look at, unlike previously 14 days of antibiotics for pyelonephritis, 14 days for bacteremia, etc. No. So first of all, look at the duration. See, when do you get drug fever? Like I said, it is only when you go into the second week. There are few conditions which require prolonged antibiotics. Those itself, there's a lot of data coming up to cut the duration of antibiotics. Now, if at all, first thing, when you have some patient like that, review the need for the duration of antibiotics. Second thing is, if at all you think it's a drug fever is a diagnosis of exclusion. So if it is that drug, then you may have to change the class. But before that, review the diagnosis itself, whether source is reduced, whether there are alternative causes for fever, whether there is metastatic seeding elsewhere, etc. before you just blame it on drug.
Since Vidya, we are really running short of time and keep on questions coming up, what we usually do towards the end of 5 minutes to see the post test, whether the persons are got the sufficient knowledge from your talk. We just put a couple of cases to discuss. Meantime, lot of questions waiting for your chat bot. You can answer typing. If you like it, you can type it there. Otherwise, you can leisurely apply also. You can send it back. Another 5 more minutes is there. You can see a couple of questions I have not asked you. If you are interested, you can answer in chat bot. Meantime, I put a posters to the participants there. Is it okay for you?
Please, sir, please go ahead.
Yeah. You just take a answer in the chat bot, whatever questions.
Yeah, done, sir.
So this is a posters for the presentations today. 60-year-old male, abdominal pain, the 101 reasons ERCP. Initially thought of some cholecystitis, calculus cholecystitis. So the gastroenterologist want to do a ERCP. Following the ERCP, now the person's develop abdominal pain, confusions, and fever. After the ERCP started, 4 days fever started now. On examinations, right hypochondrial tenderness was noticed. Urine routine showing normal. WBC count was elevated. So please, participants, if you want to get real utterance for today's sessions, you need to answer the postage. That's a part of your routine programs, what we are conducting. So what will you do now? How many say I will want to start antibiotics? How many say I want to send blood cultures? Send pan cultures. Plus imaging I want to do. All of the above, none of the above. So those who want to get utterance today, please go ahead and vote so that we can discuss at the end of our talk there. So people are saying 1, 2, and 4. So they want to start antibiotic, they want to do the cultures, but not pan cultures, and they want to image also, and they say all of the above. So a lot of answers is coming up there. So yes, those who are answering definitely will get that attendance for today's session there. Don't worry about it. Okay. So already Dr. Vidya summarized most of the things. I just want to recap what is happening today. So this case, usually the first and foremost thing in your any fever, whether it's infections in ICU, 1 second. So why the sessions we put for PGs today? The frequency of fever in his ICU is quite number. For example, it varies anywhere between 26 to 44%. Presence of fever often prompts to changes to the proper management. The question of fever in ICU is associated with adverse outcome. People are worried about when the patient's happening fever, people are really worried about it. And this is a real worry for us. When any fever, people keep on changing the antibiotics, keep on adding the antibiotics, changing antibiotics. This is not a cooked up one. One of the ICU have taken up this photograph. They keep on changing antibiotic, keep on sending. Why? 1 episode of fever. But the patient is clinically stable, but people are keep on sending antibiotics, keep on sending cultures, reacting to the cultures. So whenever you encounter your patients with infections, whether OP or IP or what, first thing you need to ask whether this patient have infection or not. That's most important thing. Whether you start empirical antibiotics, sending cultures, you need to ask, does this patient have infections? That's what she clearly told in the presentations. First case, do in proper examinations. If you do a proper examinations, you get the answer. People are asking about aspergillus is grown in a ball or not, but what sort of host? That's most important thing. Go with the clinical picture, don't go with the lab picture alone. Go with the clinical picture that is most important for you. And we need to know when you're dealing with an ICU or what patients or hospitalized patients, we need to know what sort of host it is there. Whether the person is coming from the community, admitted with fever, or developed fever in the hospital. That's most important thing. Whether he came with fever to the hospitals or he developed fever in the hospital. Then what sort of host? Whether the person is an immunosuppressed, any transplant host, any neutropenic host or not, whether the person is elderly with comorbid conditions. Similarly, previous surgeries, previous antibiotic exposures, all taken into considerations in your assessment. Don't go with picture bits and pieces alone. For the fever head to toe causes, we always start from head to toe, usually for meningitis to meningoencephalitis. Similarly, pneumonia syndromes or abdominal means intra-abdominal sepsis like cholangitis or peritonitis. We need to think about it. And urinary tract infections, skin and soft tissue. Always, when you think some infectious etiology, think broadly non-infectious causes also. She clearly told a couple of cases also. She shown how the non-infectious causes mimicking it. But the bottom line is, don't react 1 episode of fever in a stable patients. When a patient is a stable, non-neutropenic, 1 episode of fever is not going to give anyway. You need to monitor the trend. You need to monitor the pictures, how it is happening. Then only you need to react. Don't react to the 1 episode of fever. And we usually say syndromic approach. She also insisted, make a syndrome. In ICU, maybe pneumonia syndrome or bloodstream infections because of the lines or intra-abdominal or urinary tract or skin and soft tissue or surgical site infections. Meningitis, yes, rarely it can happen, particularly post-neurosurgery settings and patients without any source. That is also going to happen. And we need to think about 3 bacteria, gram-negative, gram-positives, And anaerobe, if at all, fungi is one more thing. And what sort of host we already discussed: community acquired, hospital acquired, neutropenic, immunocompromised or not. I told the percentage, this is one of the data. Usually pneumonia symptoms is more common in ICU settings. Pneumonia symptoms is more common, and urinary tract infection is also next followed it there. So we usually put the four W's here, either pneumonia or wire. Wire means line related things or wound related things or water related like urinary tract infections. Keep in mind. Examination is most important. Nowadays, mostly they use ultrasound. That's called focus. Point of care ultrasound, they're doing it now. But instead of point of care ultrasound, do a proper examination first before you go for a point of care ultrasound. That's more less important to me there. As I told earlier, think broad. These are all the non-infectious causes. When you think infectious causes like breast fever, acalculous cholecystitis, sinusitis, because the patient is on Raynaud's tube long time, sinusitis can happen, thrombophlebitis can happen, DVT can happen. These things are the differential diagnosis. Pancreatitis, all these things is differential diagnosis, little broad, and even drug fever is one of the common entity we can encounter. And bloodstream infection means what are all the organisms? Community acquired and healthcare acquired is slightly different. For example, pneumonia, community acquired, the chances of pseudomonas is less likely. On the other hand, healthcare acquired pseudomonas acinetobacter is more likely. Similarly, the resistant bugs is less likely if the person encountered meningitis, because streptococcal pneumonia in India is mostly penicillin sensitive or ceftriaxone sensitive. Resistance is a bit low. So we need to decide what organism is going to cause. Know the bug, that's more important. First thing, know the host. Second thing, know the bug. Third thing is know the drug. This is called the spectrum. These are all the common antibiotics we use in ICU or hospitalized patients. The most bread and butter is beta-lactamase inhibitor because the resistance of third generation cephalosporin in India is very high. So if you think the person has got UTI or the person has got intra-abdominal, if you think gram-negative cover is required, the ideal drug in Indian scenario is BLBLI. The person is hypotensive, we can go with carbapenem also. But the chances of ceftriaxone, if you think gram-positive agents like streptococcal pneumonia is fine. Otherwise, if you think the person has got skin and soft tissue, we need to go with proper gram-positive agent like Linda, Tico, or Vanco. So this is depends upon the bacteria also. This is a graph we put always what agents I am taking it, what drug I can use it. Green means definitely will work, red will not work. For example, linezolid has got no gram-negative cover. Tico has got no gram-negative cover. Think about it. TG is broad, but it won't cover pseudomonas. This is the thing. And a lot of newer agents coming up. Ceftazidime avibactam is coming up now. Soon, like a cefepime enmetazobactam. A lot of agents is going to come. Keep the molecule in. The spectrum card, keep in the hand. You know the spectrum card is easy for you to choose. And depending upon the site, if it is respiratory tract, previously we say polymyxin, but nowadays we prefer ceftazidime avibactam plus aztreonam, provided the synergy is present. Intra-abdominal means PG cycline is a better drug. Urinary tract, colistin is a better drug. One of the questions people are asking about polymyxin B. Polymyxin B in the urine is very less, but colistin reaches. Suppose if you want to use another polymyxins, use colistin, polymyxin E rather than polymyxin B. Meningitis means again colistin is a good drug compared to the polymyxin B. PG cycle will not go to the brain. So know the site, that's most important thing. But most important thing, Indian patients are paying for the packet. Think about the cost of the drug also in your selections of antibiotic. This is not written in the Western guidelines. And daily you need to reassess. When a patient's in the hospital, do a proper examination. Don't think one examination is fine. Do the proper examinations daily. Think about it whether I need to de-escalate or discontinue the antibiotic. Now the mantra is discontinue, but at least try to de-escalate if you start broad. Once you know the organisms, patient is clinically better, try to de-escalate. That's most important thing that's required for you. So these are all the essential steps. Think about the host, make the diagnosis, get the bug. That is more important. Send appropriate samples for cultures, not all samples. Think the drug based upon the spectrum, based upon the penetrations, based upon the resistance pattern. And finally, short is sweet. Short is sweet. A lot of data is emerging. Short is sweet. You can use biomarker like procalcitonin. Don't use the procalcitonin to start antibiotics. Stop antibiotic, yes. For all organisms, the duration is bit less. So if you want to learn more, because I put a lot of posts now previously, but now we are moving to newsletter format and podcast is coming up next week. This is a dedicated group we are coming up. Couple of like a previous group has got pharmacologists and pharmacists formed to join the thing. So we are removing the thing. We are creating a new group. Those who are interested, scan, fill the your details. Then you send the QR code so that we can include the thing. And a lot of people blocking our accounts also. Last meeting, we find a lot of difficulties. So those who are sending the request, we can scan your profile, then only we are going to allow you there. you want to learn these things, yes, you can create, scan it and attend it there. That's more important for you. People keep on messaging me there, but this is a QR code for you. And last couple of minutes, any questions to the faculty? Think we are overshooting our time, but it's okay. We can just take a couple of more questions. The last minutes, 8:30 is the time, but we are already 6 minutes over. Yes. Any questions to ask the chat bot? I just checked because I'm not checking the last 6 minutes. I'll stop sharing now. Yeah. Yeah. QR code is not working, no problem. You can send the message to the number there. I can take care of the thing. Patients having like a few enlarged lymph nodes, antibiotics should be given or not. That's what we are discussing. Make your syndrome. Mesenteric node means whether this is a typhoid or whether the person has got tuberculosis or non-infectious. If the clinical picture fits into some of the diagnosis, some of the syndrome, yes, send appropriate sample. If needed, typhoid means blood cultures. If you think TB means take the node. So make a syndrome and send it. Role of corticosteroids in sepsis. Lot of emergencies coming up. Lot of evidence is coming up for the corticosteroids. Is getting harder. Usual dictum in sepsis when the person is hypotensive, requiring 2 vasopressors. Usually hydrocortisone we prefer. I'll put the number there so you can send a message. So any other questions in the last minute? I will put the number. Okay. So if there's no more questions, I sincerely thank the APA and ICP for giving this wonderful opportunity. And I thank Dr. Vidya for sparing the time with us. And participants today were very active. There a lot of interactions is happening. This is a way you need to interact and get the attendance rather than just putting your name. So this will make you learn also. And the exams is also coming up. The short certificate case is getting over by June, July end. Already the organizers asking for the questions for the examinations. So start preparing your examinations also. Don't think this 140-minute session is going to learn everything. This is only for your starting point. The next 1 week, you need to learn about how to approach infections and fever. Usually, I put a couple of literatures, but Dr. Vidya has already shown the Society of Critical Care Medicines and IDSA put one new guidelines in 2023, how to approach fever in the ICU. Clearly, it's come up. That's the latest guidelines. I usually shown, but I not shown today there, but you just read the guidelines and see practical cases and keep on interacting in the group what I created for you, the WhatsApp group what I created for you. Please interact. If any questions also, you can put it. I can forward to her and get the reply also. So this is only a starting point for this week. Yeah, this week focus towards all nosocomial and hospital-acquired infections and healthcare-acquired infections only we are going to discuss. Next part is probably sepsis and a couple of topical infections and ICU we are discussing it. Then we go into the more focused discussions of TB, HIV, and pregnancy-related and special situations we are discussing it. Then final last 2 parts is a recap of everything and go for final examinations. So thank you once again. Thank you all the participants. I'm signing out. Thank you, Vidya, once again.
Thank you, sir. Thank you. Thank you all.